Welcome to our Zoom meeting today, and we will have some items in the agenda. And the first one, we will welcome Dr. Rayan. She was one of the fellows in this program, and she graduated, she attended residency and then followed by a fellowship. Welcome to Dr. Rayan. Welcome to our program. Please take it from here, and we are looking for your input. Thank you.
Thank you, Dr. Nadir. Thank you for having me today. I'm glad to meet with the current fellows, and I'll start by introducing myself. I'm Rayan Musa. I'm currently working as a geriatrics fellow at the University of Arkansas in Little Rock. I don't know if you guys want the session to be a Q&A, or that way we can have more interaction, or if you want me to go through my agenda, but I will tell you more about myself also before we start.
You can go ahead. Thank you.
Okay. Thank you. I graduated from medical school in 2014 and Omdurman Islamic University in Sudan, and moved to the US in 2016. And then I started my USMLE journey. By that time, I passed all my studies by February 2019, and I applied for that match cycle. In September of 2019, that was my first time. I thought, the process is just easy. Get 2 letters of recommendation and go apply. Anyway, I had enough time from February to September to have some clinical rotation, get letter of recommendation, and I applied. I did not get any interview that season. So December of 2019, I realized I have to do more work. I need to learn more about research to get more, applications in my CV, and to improve on my application in general. January 2020 is when I started preparing for the following match cycle. I started a research writing and publishing training. Through that, I was able to publish 5 papers. It was the COVID time, so I heard about this fellowship, got in touch with Dr. Nadir, and luckily I was able to join. It was a, good program to learn about research, more about geriatrics, and that's what solidified my interest in being a geriatrician. I had also a couple of publications through this program. It was nice working with the team and other fellows. Made lots of connection, of course. So I had the time from January to September that year just to improve on my CV. So I got the publication, started the fellowship. I also applied for a Master of Public Health program, and they got accepted. I also work as a dialysis technician at Avera Hospital in South Dakota, and also the Department of Health was hiring by that time for people to work part of the epidemiology team just because of the COVID in Indian or Native American reservations. So I joined them also. It was busy time, having lots in my plate, but it's still, by the time of submitting my application, I added all of that. I added lots of new work and research experiences and publications. Some of my projects were not published yet, but still I added as ongoing thing. And I applied. That was my second time. I received 3 interviews, 2 in university programs and 1 in a community program. 2 were family medicine and 1 was internal medicine. And I matched into the University of Arkansas family medicine residency program. The first 6 months, were a little tough for an intern, but I did it. And then by that time, I held off studying for my MPH. I resumed taking classes after 7 months in residency or so. And I finished my MPH last year in May, and I also graduated from residency June of last year. And I stayed and continued with the University of Arkansas. Now I'm a geriatrics fellow, and my graduation is next week. I'm so excited. It's been a long journey, but I'm happy with what I have achieved. I will start my first attending job in Wisconsin. So I will be moving to Wisconsin soon. And I will also start Master of Computer Science in Clinical Health Informatics at just give me 1 second, prayer time. I will start a Master of Computer Science, Clinical Health Informatics with the University of Wisconsin. So this is what I did so far. I'm working on a book. I'm hoping to publish it by the end of this year in geriatrics. It's called Essential Geriatrics, Guidance for Medical Students and Early Career Provider. It's just because I felt there is a gap in the information about geriatrics, especially what the medical students and residents need to learn, versus what is available. All of these books are like fellows level or geriatricians level. So I'm happy to meet with all of you today, and I'm ready to answer all of your questions if you have any. Otherwise, I have a few points that I would like to cover.
Thank you so much. And we are very happy to hear all this achievement and success. We are very pleased, and congratulations for your achievements, and good luck with finishing the fellowship. That's a great step as well. We need
Thank you.
more of you. Yeah, thank you so much. So if any of the fellows have any questions, please raise your hand or jump in. And I forgot to say Eid Mubarak to all of you. May Allah accept from you guys, and wish you all the best.
Yes, happy Eid.
Happy Eid.
Just I have one question.
Yes, go ahead.
I'm asking about, is it easy to do master during residency? As you know,
It was tough. It wasn't easy, especially the first year. But I did it. I did it because I really wanted to continue on my MPH, and I'm really interested in public health in general and healthcare administration. And I was taking my major was healthcare administration, nursing home administration specifically. And they knew I'm going to go into this geriatrics fellowship, and they want to be a nursing home medical director one day, all that kind of thing. So I just pushed so hard to get it finished. It wasn't easy, and I'm a mom, so I have also some family commitment, but you can do it. If you really want to do it, you can.
What is the timeline of the program usually? 2 years or 1 year?
It depends. You're the one who decide. It is, let me see, it's 40 credit hours, which is around 13 course. So you have to take 13 course if you want to go full-time or part-time. Or I started full-time and then I switched to part-time. During residency, I was taking sometimes one class per semester. One class is like 3 credit hours, and you will need, let's say, 3 hours at least per week, 3 to 6 hours to go over all your work and everything, your homework, to go over the reading material and everything. So just taking one credit hour is doable. At the end, I took 3 credit hours in my last semester because I wanted to graduate and finish both residency and master at the same time. But on my second and first year of residency, when I was taking one class, it was just easy.
Okay, thank you. Thank you.
Mm-hmm. Thank you for your question.
Any other questions or comments, or if you want to share some of your perspective, some of the tips and advice, if any?
Yeah.
Thank you.
Yeah, I saw something in the chat about Sioux Falls, and then it got lost. That's where I used to live. I don't know if anybody from Sioux Falls here today. Okay. So I will start with saying I was in your place one day. I wasn't sure if I will make it. Okay, Marianne person. Okay, hey Marianne. So I wasn't sure if I will make it. The journey was really tough. But I did it, and you also can do it. This fellowship is really good. You will get connected. Even after graduation, stay connected with your fellows. If anyone match, just be happy for them, because that's mean you're the next. That's mean you have a connection in a program, and just keep pushing. So let's see. Okay. Okay, I'll just tell you a few things about residency, since you're getting ready to apply for the next season. You guys have 3 months left, but I hope that you started preparing early. Start working on your CV, do your program search by yourself. That will be the best thing. At least that way you will make sure all the programs that you are applied for, you met their criteria. I did my search by myself. It took me like over 2 weeks to do it. It was very detailed. I looked all the program website for scores and year of graduation cutoff and everything. Also, start working on your CV. I got some help from the Department of, it is like, I'm trying to remember, the Department of Human Service or something. They have people that can help you with writing your CV, prepare for interviews and everything, and that was free. So I utilized that, and it was my resource until I prepared everything. Also, for your personal statement, of course, write about all your journey, all of your achievement, and but still don't just summarize your CV and write it here. They want to know you more as a person. Of course, by this time, probably you already had your rotations done, or you have something arranged. Otherwise, SAPA, they are helping the Sudanese American Physician Association. They are helping. Myself, I just Google search for hospitals that offer observership in my area, and then I found a rare hospital. So I just got to choose 2 physicians, got their emails, sent them letter of interest, and then they replied, and I got to do the rotation with them and had 2 letter of recommendations. Also, research is really good, and it helped with matching, I would say, because the first year I applied, I didn't have any research. I got their interview. The second year with this fellowship, I was able to publish a couple of papers. Even those were not published, were still in progress, I was still able to add them in my CV. So that was really helpful. So just keep working on your research. If you get any opportunity to present at the AGS conference or any conference, that's also a plus. Anyone had any questions so far? Or do you have any specific thing you want me to talk about?
Hello, Dr. Rayan. Thank you. I just want to ask you about the master. Was it online?
They have online and in person. I had to finish it online because I moved anyway out of South Dakota, but I want to continue with the same university. Although the University of Arkansas, they offer 50% discount for their residents and fellow on education. So, you know, if you start in any place and then you match, you can always transfer the same credit hours that you studied, and then you can get discount if you match in a university program. It depends also on the university, but at least that's what the UMS offers.
Okay, thank you.
Mhm. And now also, it doesn't matter if it is online or in person. So I would say if you find any online opportunity, just go ahead and do it. At the end, you know, they don't write on your certificate if it was online or in person. And definitely you studied. That's how you passed. You know, you would really get tested. It's not even easy. And then they will have, you know, ways to monitor you while you're taking tests, things like that. So it's really good to do it regardless of if it's in person or online. And at the end also, you can be a certified healthcare professional, a certified public health professional, if you get the MPH degree, which is another also title credentialing thing. And with that, you can get more work opportunities. I took the CPH test and now I'm certified public health professional, but the test, it wasn't super easy, but I just used my knowledge from medicine and what I have learned during my MPH. And then I sat for the test and I passed it. That will open more doors for you if you want to work with, you know, CDC or anything like that, if you're CPH.
Thank you, Dr. Rayan.
Thank you.
Any other questions? If not, Rayan, can you provide your email just for contact if anyone would like to?
Yeah, I'll be happy to help. I used to work as executive board member at SAUDA, Sudanese American Doctor Physician Association, and they helped through the 2 previous match cycle with interviews preparation and CV and everything. I no longer work with them, but I'm still happy to help if anybody have anything or question. Let me just add my email to the chat.
We are so happy for you, Dr. Rayan. You did a lot and achieved all the aspects. So we are very proud of you, and we wish you all the best. And
Thank
you
you.
did it. Well done, and congratulations.
Thank you. My email in the chat, feel free to contact me if you need any help with anything. It's my pleasure meeting with all of you today. Thank you for having me.
Thank you so much, and good to see you in person. And thank you, and I wish you all the best, and good luck with the next step. What's the plan next? You after graduation?
I'll be working in rural Wisconsin as geriatrician and primary care, and then I will start my Master of Computer Science in Health Informatics.
Oh, good, excellent. All right,
Yeah.
so let's post it, and I wish you all the best, and good luck. We really need you in this country. We need more physicians like you, and geriatric and public health. Thank you so much, and really appreciate your tips and advice.
I really appreciate all your support and all what you did. And I would say this fellowship is what solidified my interest in being a geriatrician. I got to learn more about geriatrics and the importance of this specialty. So
I'm very glad, and really thank you so much for coming over, and thanks for your help and service, and all the best.
okay, have a good one. Bye.
Have a great one. Thank you so much. So for our next speaker, Dr. Liena, when you are ready, we will talk about food disorders. Thank you so much, Dr. Liena.
Hello, everyone. How are you doing? Happy Eid. I am sharing my screen now. I hope you can hear me.
Yes.
Okay, great. Hello, my name is Liena Mohammed. I am from Sudan, newly graduate 2022, and I will be presenting the gait disturbance. Is the screen is visible for you?
Yes.
Okay. The gait impairment. In general, what is gait impairment? Gait impairment refer to any deviation from the normal walking due to neurological, muscular, or skeletal, or even sensory dysfunction. It affects the speed, the rhythm, it affects the balance, the posture, the coordination, and the limb movement in general. So the objective of this session will be to how to do a diagnostic evaluation of the gait dysfunction, how to assess, and what are the interventions that we are going to do to reduce the impairment and the function in general. Again, the topics, we will start by the epidemiology. Gait is a predictor of functional decline. It is very common and predictor of functional decline. It means that because walking is a final output of multiple integrated systems, and if one fails, then gait is often the first one to show. Because walking in general requires good cognition. It means we will need to have an intact frontal lobe, attention, planning. It also requires motor strength from the corticospinal tract and basal ganglia, sensory input from the proprioception, the vision, the vestibular, and we will also need to have a good balance from the cerebellum and to have joint and muscles to be intact. So the musculoskeletal system is also involved. That's how it is multisystemic. So when the gait is off, it is rarely only about the legs. So certain gait-related mobility disorders progress with age, and they are associated with morbidity and mortality. Community dwelling olders, adults with gait disorders, particularly the neurological abnormality, are the higher risk for institutionalization and death. So the gait, it predicts the increase of fall risk, the gait abnormality, and the loss of independence. It could be associated with cognitive impairment, and for elderly population, it means more hospitalization and more institutionalization and even death for them. The glossary and terminology of gait abnormalities are very, very wide. In order to understand what is gait impairment, we will need to know what is normal gait. The normal gait cycle constitutes of two main phases. The stance phase, which means when the foot is on the ground, when we are applying pressure on the ground, and this constitutes 60%. And then we will have the swinging phase, when you lift your leg, you lift your foot from the ground, and this is 40%, which is faster. This is the normal. Any disturbances between these cycles, it will lead to abnormal gait, and abnormal gaits are very, very, very wide, starting by the ontologic gait, which is by far the most common one. It is the walk of pain and usually not neurologically induced. So the patient will reduce the stance phase of the painful leg, and this will create a short stance phase, a shorter stance, and it will lead to a faster gait at the painful leg, and it would be asymmetric between the two legs. So one leg would be faster and the other would be slow. So mainly it's pain induced. The second one is the circumduction gait. And before we know how it looks, the circumduction gait happen when the leg cannot flex the knee and the ankle, or the patient cannot do foot dorsiflexion. It means we can't raise the leg. So in the body to compensate, or it compensates by swinging the leg out. So their swinging phase will be outward laterally in a semicircular movement of the hip. So they use the hip to compensate for they cannot raise their leg to avoid dragging the foot along the ground. And this is the meaning of circumduction. The cause is usually neurological. For example, hemiparesis after a stroke, from cerebral palsy or multiple sclerosis. It could also be associated with ipsilateral arm hemiparesis. If it is, of course, after a stroke, we will have arm-leg deformity. Then third, we have the equinovarus. Equinovarus, let's break the terminology. Equinus is meaning the plantar flexion of the ankle, usually due to muscle spasticity, and varus mean inversion and supination of the foot, usually also due to muscle spasticity. So if you have like great imagination here, the patient will be walking on the lateral side of the forefoot and the toes. Usually the cause is also neurological insult. People will have both circumduction and equinovarus walk together if the injury is very severe enough. And then we have destination. It's not a full gait, actually. It's not a full gait by itself. It's a description of involuntary quickening of the steps. And it's a part of a Parkinson gait, or a phase of a Parkinson gait. Then we have the foot drop and the foot slap. The foot drop is also common. It means the person cannot raise the toe due to failure of dorsiflexion of the ankle. So it could be due to one nerve injury, usually known as the common peroneal nerve. And then it could be also caused by nerve root injury, like in the radiculopathies, or from a neuromuscular disorder, or even after stroke. So it is present in many disorders. And people with foot drop, their gait would be described as a stoppage gait. It means the foot excessively, they raise their foot excessively high in plantar flexion position, so that their heel, so that their toe does not reach the ground or do not hurt. And when they try to walk, their heel reach the ground very fast, and it causes the foot slap or the sound of foot slap. So we have the foot slap again. Foot slap here is when the foot slap, as we describe, making an audible foot to floor hit. Again, it's just a description. And number 7 is the freezing of the gait. From the name, it is a sudden and brief episode of inability to move despite the intention to. And usually, it's also a part of a Parkinson gait. Then again, we have the geno recurvatum. It means hyperextension of the knee. It means hyperextension of the knee. Wait, like it means the knee is bending backward when it should be straight during walking. Again, wait, what? Isn't this normal? Actually, for me, when I searched for this, it was surprisingly abnormal. Because in the stance gait, when we are walking, the knee should not be extended. And the extension of the knee during walking, it should be less than 5. So the maximum is from 0 to 5 degrees. It is considered normal in children and those who are highly flexible, like those with ligamentous laxity or those with Marfan, Ehlers-Danlos syndrome, who are way more flexible than the normal population. So the hyperextension is abnormal and it is painful, and it would lead to complication like the locked knee and etc. Then we have the propulsion and retropulsion. They are connected together. The propulsion is the phase when the body is actively pushed forward, and it occurs during walking at the end of a stand phase. It looks like they are being pushed during walking. They look like being pushed forward. The retropulsion, it's an involuntary backward movement. So the patient will be looking like they are being pushed backward by something. They both occur together in postural instabilities in general that involve the basic ganglia dysfunction. Then we have the scissoring, very common. Scissoring is a spastic gait pattern where the hips are abducting and they are internally rotating, causing the legs to cross over each other's like scissors. The base of they are crossing the leg, so they are narrowing and getting closer to each other. The base of their support would be narrow, and this will lead to more imbalance. And it usually occurs after a stroke, a brain injury, or in children, cerebral palsy. Then we have the established gait. As mentioned before, it occurs with the dropped foot. It's a compensatory high stepping and leg raising to prevent dragging of the foot. So it's an exaggerated hip flexion and knee extension. We have the Trendelenburg gait. It's a shift of the trunk over the affected hip. So it is caused by weakness of the hip abductors, which are, I guess, the gluteus medius and the gluteus minimus. They are causing contralateral pelvis drop. So weakness on the affected limb will lead to a compensatory mechanism. It will lead to a pelvic tilt and a pelvic drop at the other side to compensate. The patient will lean toward the affected limb and will drop the other side of the pelvis. So a positive Trendelenburg sign, as you can hear, it means when we ask the patient to stand on one leg, if the opposite side drops, it means that it is positive. They have an ipsilateral abduction defect at the leg they are standing on. Lastly, we have the turning block. It's moving the whole body while turning, meaning the patient cannot turn only their hips and shoulder. When they want to rotate, they turn the entire body as one rigid unit. And it is also a part of a Parkinson gait. So we will have the conditions contributing to the gait disorders in primary care are very multifactorial, and they involve multiple systems. As we mentioned before, the neurological systems, the musculoskeletal, sensory, even psychiatric, and they could be also as a side effect of medication overdose. So they are degenerative joint diseases, acquired musculoskeletal, intermittent claudication, orthopedic surgery after stroke, postural hypotension, dementia. It could be just fear due to visual impairment. So how to know exactly the cause for gait abnormality? It would be through doing a detailed history and examination, gait observation, and even laboratory test. But before we go through that, we will have the classic neuroanatomical classification of the gait disorders. We will have a low, middle, and high. The low level, it means they are involving the peripheral nervous system, whether they were motor or sensory. When we say the peripheral nervous system, we mean the feet, the nerve root, the peripheral nerves. So the sensory of these levels may overlap when certain disorders involve multiple levels, like in specific disorders like the Parkinson disease, they involve the cortex and subcortex. Okay, when we go to the peripheral sensory dysfunction, it means we have an impaired transmission of the sensory input from the peripheral nervous system to the central nervous system. So there is a impaired transmission from down going up, transmission of proprioception, vibration, light touch sensation. So the patient will primarily will be like they cannot feel the ground. They have abnormal sensation, for example, in specific disorders like uncontrolled diabetes or risk factors, or could be a direct cause, vitamin B12 deficiency, they cause peripheral sensory impairment, alcoholism, some specific drugs and chemotherapy. So in the physical examination, we will have decreased sensation, decreased vibration, decreased proprioception. Usually the muscle strength would be normal unless they have an association or an overlap between the peripheral sensory and peripheral motor. They would be decreased. And we will have a positive Romberg sign. It means that when the patient when they are standing with their eye closed, they fall. But when they are standing with their eye open, they can't stand. They don't fall. Once they close their eyes or the light is shut, they just fall. This is a positive Romberg sign. So we'll have the conditions that cause peripheral sensory dysfunction or peripheral neuropathy. As we mentioned, the causes could be diabetes, B12 deficiency. We will have some vestibular disorders and visual impairment. Regarding the visual impairment, it is not a direct cause, but rather a lost compensation. The only thing that was keeping them standing is the visual input, because they don't have sensory input. So the brain, they don't have sensory input. So when they don't have sensation and they cannot see due to visual impairment, of course they will fall. The other thing here is, since they cannot feel the ground, they will have a stoppage gait. They will have their gait abnormalities will be possibly stoppage gait, also wide-based gait. It would be unsteady. How unsteady? Because some vestibular disorders would be affected, like the peripheral nerves. When we say vestibular disorders, we mean the peripheral vestibular apparatus here, like the cranial nerve number 8, which is known as the vestibulocochlear nerve, and the labyrinth. So the patient will present with vertigo, unbalanced gait, unsteadiness, multiple fall, not due to their brain is affected, but the peripheral nerves are affected here. So they will have a waving, drunken, falling to at the affected side, and they will have uncertain coordination regarding the peripheral sensory dysfunction. When we move on to the peripheral motor dysfunction, it refers to impaired movement due to damage to the lower motor neuron. So we will have a lower motor neuron lesion, like an anterior horn cells of the spinal cord, like nerve root injury, peripheral nerves, the motor part of the peripheral nerves, and the neuromuscular junction, like the myasthenia gravis. So the classic presentation would be they will have a severe muscle atrophy and weakness. They will have fasciculation of the anterior, if the anterior horn cells are involved. They will have hyperreflexia and areflexia. The muscle tone would be very decreased, and they will present with flaccid paralysis other than spastic. So painful, the conditions could be painful or deforming conditions, or they could be focal, myopathic, neuropathic weakness. Painful deforming conditions like osteoarthritis of the knee, the hips, osteoarthritis of the spinal cord, or even spinal spondylosis that occurs aging, they will lead to abrupt postures. So their posture will be stooped. It means they adjust their posture in order to decrease the pressure on the affected side, because the affected side is painful. During clinical and physical examination, there would be pain, decreased motion of the hip, the knees, or spine, signs of arthritis, thoracic kyphosis, etc. Their gait would be antalgic because it is painful, with shortened stance phase on the affected side. They will have a Trendelenburg gait. Regarding the focal myopathy and neuropathic, like the myositis or like the Guillain-Barré syndrome, like the diabetic mononeuropathy, they will have a proximal muscle weakness, or it could be a distal muscle weakness, as in Guillain-Barré. And their gait would have a Trendelenburg gait. They have a waddling gait. And waddling gait, it's a broad-based gait caused by weakness of the pelvic muscles and the hip abductors. So the pelvis is tilting excessively while they were walking. And this occurs in specific disorders that involve these muscles, like the Duchenne muscular dystrophy that involve the hips. This is the waddling gait. So we will have to the postural and locomotor impairment. The postural impairment means the inability to maintain an upright balance or to stand in one posture. So it primarily involves the central nervous system and the sensation. The locomotor impairment means inability to move forward or inability to do coordination. So they will have general ataxia. They will involve the motor, the muscular, the joints, and the two categories, like the postural and locomotor impairment, usually coexist together. Examples for them, we have the cerebellar ataxia. Cerebellar ataxia, we will have a poor trunk control in coordination or cerebellar signs. Regarding their gait, their postural impairment, that would be imbalance at the trunk level and the legs level. So we will have what is known as trunk sway. They could not even stand still without imbalance. Not only associated with walking, it is also associated with standing. And they will have a wide-based gait. Regarding their locomotor disturbances, they will have irregular steps. The other example is Parkinsonism. Parkinsonism is a clinical syndrome. It is diagnosed to have a bradykinesia, plus other disorders like rigidity, wrist and tremors, and stooped posture. So their posture would be stooped. It means they would have flexed hip, flexed knee, flexed elbows, with limited range of motions, and in general, and limited arm swinging. So they would be very stiff or positional like a robot. And they will look like they are barely moving while they are actually moving. Their locomotor impairment would be the bradykinesia, which is very important for the diagnosis. It means they will have small shuffling steps that would present with freezing at initiation and followed by festination, which is a speeding, which was what we mentioned before. And when they are trying to turn, they will have a turn on block. It means they turn their whole body instead of their hip or their head or their shoulders. So it's very unique. Then we have the hemiplasia and hemiparesis. Hemiplasia and hemiparesis, they are usually caused by upper motor neural lesion involving the brain, like stroke. Hemiplasia means complete paralysis, and hemiparesis means only weakness. And they are both spastic paralysis. So the patient will present with hypertonia, hyperreflexia, because it is an upper motor neural lesion. They will have an upward curving of their toes after stimulus, which is known as a Papinski sign. And their gait would be circumduction, which is we mentioned before. The last thing regarding this category is the paraplegia and paraparesis. It is similar and also caused by upper motor neural lesion, but this time involving the spinal cord. So paraplegia and paraparesis mean involving the lower leg. So in hemiplasia, we have arm and leg, and paraplegia, we will have the two lower limbs and legs. Again, paraparesis is weakness, paraplegia is complete paralysis. So their legs would be bilaterally affected here, leading to a scrapping feet, which is another name for a dragging feet and dropped foot. A bilateral leg circumduction here. The last category is cognitive and white matter disorder. And when we say cognitive impairment, it means we have an impaired attention, impaired memory, executive functions, which is the planning, the visuospatial defects. In other words, it means dementia, involved in all its different categories and subtypes. The one mentioned here is the NPH, the normal pressure hydrocephalus, which is diagnosed by triad of cognitive impairment, magnetic gait, and urinary incontinence. Their gait will involve range of findings, may include difficulty initiating the gait. They will have freezing, like apraxia, and shuffling gait, similar to that seen in Parkinson, but here it is wide-based. In Parkinson, we have a very narrow-based shuffling gait. Here, this is wide, this is magnetic gait. So they will look like their feet are glued to the floor, but they have a normal based gait. Then we will have dementia, Alzheimer disease. Alzheimer gait is, well, Alzheimer's, they are not known for their abnormal gait. They are mostly known by their very bad short-term memory and visual spatial impairment. The gait impairment would only be visible when they are in their mid stage or their late stage of the disease, and it will be slow with hesitancy. But usually at first they will appear normal. Regarding the gait assessment, careful medical history and physical examination can elucidate contributing factors because the causes are very many and integrating, so the assessment should be very detailed. The key components of the assessment should have at first gait observation even before asking for history. Then we will have a detailed history, neurological examination, and then we will have the specific gait assessment tools. Some specific systemic disorder will require laboratory, will require imaging and specific diagnostic techniques and tests for specific disease. So when we will start by history and physical examination. To evaluate for evidence of subacute metabolic diseases, like alcoholism, B12, uremia, any specific disorder related to liver abnormalities, and cardiopulmonary disorders, like the COPD, like the heart failures, like the anemia, because their gait are also abnormal, because their gait would be very fatigued gait, very slow, and they are stopping many times during walking. This is also considered abnormal. We will have attempt to identify the motion-related factors by provoking both vestibular and orthostatic response. This is in specific disorders regarding the orthostatic hypotension and vestibular dysfunction, like we will have the Dix Holbein test, which is a positional test diagnosed to provoke vertigo and nystagmus. So we will sit the patient in a specific position, and we will tilt their head for a specific amount of time, and then lay them back, and then tilt it again. Following a specific manner and timing, we will elicit a vertigo and nystagmus, and this is used for specific diagnosis for vestibular diseases. Hopefully the benign ones. The supine and standing blood pressure, this is used for orthostatic hypotension, because the diagnosis of or the definition of orthostatic hypotension is decrease or fast decrease in the systolic blood pressure by 20 and diastolic by 10 when moving from supine position to an upper standing position. This is enough for diagnosis, but we also have a tilt table test when tilting the patient to see if they will develop hypotension and syncope. I don't know if it is ethical. Lastly, we will have the vision screening, the vision for acuity, because vision impairment will also affect the gait, as we mentioned before. Again, regarding the history and physical examination, we will evaluate the neck, the spine, the extremities, the feet for pain and deformities, and the limited range of motion, particularly regarding specific contractures and disorders. We'll measure the leg length discrepancies after a hip prosthesis and devices. We will also, if needed, we will measure the distance. Again, with the neurological assessment, it is very essential in Gait because most of them are associated with neurological disorders. So we'll assess the physical neurological strength, tone, sensation, proprioception, vibration, with the toning fork, and the coordination to assess for the cerebellar function, the station, the gait. We mentioned the Romberg test for simple postural control. And then we will have the lab test. Yes, the laboratory and imaging assessment. They are not usually done unless we are suspecting a systematic disorder. So like the diabetes, like B12 deficiency, like thyroid disorder or liver and kidney disease. The imaging techniques are indicated when they are not usually indicated, but their indication would be when the onset of the disorder is very sudden, acute, like in stroke, or when the disease is progressing rapidly, when we have signs of apomotor neuron lesion, or autonomic impairment like urinary incontinence or sexual dysfunction. We would need to do some spinal imaging, radiograph, CT, MRI. MRI is preferable. And the spinal cord abnormalities. Regarding the performance-based functional assessment, these are the objective measurements of how the patient are physically performing their task related to walking and balance, mobility. And we will be measuring this during under observation. So he would be like doing the test in front of us. It's usually the next step after taking history examination is to do the performance-based functional assessment. And so we will have a group of standardized tests to evaluate the functional capacity and to predict the decline, the functional decline. And they are a group of disorders. So the first one is the 6-minute walk test. Yes, also called as a comfortable gait speed and related endurance measures. They measure the speed, the gait speed, and the endurance and cardiopulmonary reserve. So regarding the gait speed, the cutoff point speed, which is considered normal, is 0.6 meter per second. Lesser is abnormal. And the gait speed is tested from standing start over a distance of 4 meters. As we mentioned, the cutoff point speed is 0.6, and the speed which is more than 1 or 1.2 meters per second are associated with better functional outcomes. The lesser are worse. And the other test is the timed up and go test, which is known as the tug test. The clinical use of this test is when it is equal to or more than 14, it will indicate a high fall risk. So the more the worse. It is not considered relatable with a specific condition. So from the name, we will record the time when the patient rise from a chair, walk through 3 meters, and turn and return and sit at the chair. So we just record the time. If it is more than or equal than 14, it indicates a high fall risk. Some disorders like cognitive impairment and difficulty completing the test due to like immobility or safety concerns, and refusal will give inaccurate results, so the test could not be reliable in specific condition in these conditions. Lastly, we will have the interventions to reduce the gait disorders. The management of gait disturbance is by reversing the cause and to improve the functional impairment. Some gait disturbances are treated. It is dependent on the cause. Some are treated with the analgesic, some will require more imaging and to stop the offending agent. Some will require levodopa trials, and some will all require physical rehabilitation, and that's it. So many conditions causing gait disturbance, and some of them are partially treatable, some of them are fully treatable. Other outcomes, such as pain reduction, may be equally important in justifying the treatment. Like patients suffering from antalgic gait, they will be treated with analgesic. Comorbidities. Some studies showed that patients with equal to or more than 2 comorbidities are more likely to fall and are more likely to have decreased gait speed, to have decreased response to treatment. And these comorbidities are the cognitive impairment, firstly, and then we will have sarcopenia. And sarcopenia is frailty. It is an age-related loss of the muscle mass and function. So they will eventually have a poor quality of life. The other comorbidities are diabetes, Parkinsonism. We will also have the depression, the visual impairment, and even the cardiopulmonary disorders. They will all decrease the outcome, the general outcome. Regarding the exercise and physical activity, well, most of them will require exercise and physical activity. The knee osteoarthritis, the goal of exercise and physical activity here is to decrease the pain and to improve the mobility by strengthening the muscles and also by protecting the joint integrity. So they increase the flexibility, and they will have aerobic exercises. Aerobic exercises means like the stationary bikes, the swimming, the walking. Particularly the anaerobic exercise, particularly with a single goal, and when provided at least 3 times per week, they show at least moderate effect on improving the overall function. Regarding the stroke, post-stroke, they found that the treadmill training may improve the gait speed and walking endurance. The electromechanical and robotic assistant, like the wearable robotic devices that will assist their movement. And the goal in post-stroke is to regain the motor function and to regain the symmetry between the different limbs. Regarding the Parkinson's disease, the physical therapy, including complementary treatment, yields short-term gains in functional mobility and gait speed, because the treatment for Parkinson is not only physical, it is mainly medical with levodopa additives, agonistic agents. So the complementary for Parkinson is also important, involving the physical therapy, involving occupational therapy, speech therapy, and some resistance and aerobic training. Then we will have the surgery would be specific to specific disorders. So the lumbar stenosis, it will have an operative treatment and non-operative treatment. Many have reduced pain after the operative, which is the laminectomies and lumbar fusion surgery if the vertebra is displaced, the bone is displaced. However, the non-operative treatment can also result in modest improvement, such as walking tolerance. Like deflection-based exercises to improve the flexion of the spinal cord, like the core strengthening, and also the analgesic is also considered non-operative treatment. The NPH, normal pressure hydrocephalus, may have short-term gait improvement after shunt placement, the ventriculoperitoneal shunt operation, but the improvement will not be maintained by long term. Regarding the hip replacement surgery of the osteoarthritis, hip or knee, the medical will involve pain relief, sizable gains in gait speed and joint motion. The mobility aid is also important because they shift the weight and they help to reduce the pain also. They will involve the lift, internal and external lift. They will involve ankle braces, shoe insert, the walking shoes with low heels, thin firm soles, the canes and the walkers, the light touch on a wall. The light touch is not just to support the weight, but also for spatial orientation and for balance. So it's also considered a mobility aid. Oh, finished. In summary, the gait disorders are common in older adults, and they are predictor of functional decline. The cause of gait impairment in older adults is usually multifactorial, and therefore a full assessment is needed and considered in number of different causes to determine the cause. Then we will have various intervention according to various disease, ranging from medical to surgical to exercise. It can reduce the degree of impairment, although unfortunately some impairment would be residual. So this is it. If you'd like to, we can go through these cases.
For the sake of time, we can skip this.
Yeah, okay, it's fine.
Thank you so much, Dr.Liena, for excellent, great presentation. Any questions for Dr.Liena or any addition, any comments? If none, I'd like to thank you again, and thanks for your help and great presentation. We'll move
Thank you.
on. Next topic.
Yes, good evening and happy Eid for everyone. You hear me?
Happy Eid to you too. Thank you. And to
Thanks.
everyone.
My name is Musab Ibrahim. I graduated from Othman Islamic University in 2022. So in this brief session, me and Dr. Gaffar will talk about systemic review and PRISMA guidelines. So in general, research types, there is three main types of research: primary researches, secondary researches, and tertiary researches. So in primary research, that involves the generation of new data through experiments, observation, or surveys. So the main idea in this type is that we don't have data. So we want to get and make the data. An example of it, randomized controlled trials, cohort studies, case control studies, and cross-sectional studies. The main type of research is secondary researches, which involves the synthesis and analysis of existing research. So the difference here is that we already have data, but we want to gather it, for example, gather multiple researches and get a final conclusion from it. It have two main types, which is systemic reviews and meta-analysis. And the third main part, which is rare, is tertiary researches, which summarize secondary research for use in practice. For example, for putting clinical guidelines, we get the data or conclusion from both primary and secondary research. So what is a systemic review? A systemic review, in general, is a structured and comprehensive synthesis of research literature on a specific topic that designed to minimize bias using transparent, strict method, aim to answer a well-defined research question by evaluating and synthesis all relevant studies. So why systemic review is important? It have four main importance. First, they minimize bias by following a strict methodology. The second is combined results from many studies to increase statistical power and precision, and also identify gaps in knowledge and guide future researches. And the final or four main points, which are considered the highest level of evidence in evidence-based medicine. If you want to do a systematic review, we have multiple steps that we have to follow or to do to ensure that we did a proper systematic review. There are 7 or 8 steps. The first is formulate a clear research question. In this step, we use the PICO format, which population, intervention, comparison, and the outcome. The population is the group of patients that we want to do our study on it. The second is the intervention. For example, the treatment, the exposure, or the test that we want to measure. The third is the comparison. It's an optional. For example, you want to compare new drug to already existing drug or treatment or placebo. And the final is the outcome or the result of our systematic review. This is the first step. The second step is we want to develop our protocol, which is like the base of our systematic review that will build our review on it. We will define objectives, also will define eligible criteria, and define our methods using Prospero platform. So in objectives, we clearly define what the review aim to assess. If we take an example in a study to compare the effectiveness of ACE inhibitor with beta blockers in reducing cardiovascular events in hypertensive adults. So this is a very clear objective of our study. In addition to that, we will define the eligible criteria. For example, we will put the inclusion and exclusion criteria depending on multiple variables. population, for example, adults with hypertension in this study. Also, we'll define the study types. We will define randomized control trials only, and we filter it from other studies. For example, language, we can use one language. And also, we'll define the publication period, for example, in the last 15 years. And also, we'll define the exclusion criteria, which is other study types or other variables, for example, case reports, editorials, or animal studies. So all that we will exclude it from our screening. And the third part is the methods, which is, for example, we'll define the search strategies like database, for example, PubMed or Covidence. We'll put also our keywords and our filters. So we will do our screening on the basis of it. Also, we'll define the screening process. As general, we will start with primary screening with the screening of titles and abstracts. After that, we will go to the secondary screening after filtering all the relevant papers or researches. In the secondary screen, we will do a full text review. And also, we will exclude a lot of papers. So at the end, we will get the filtered data, and we will do data extraction and we build our research on it. And also define data extraction method. We can use also Excel sheet or Confidence platform. And also we'll define bias assessment risk tools. So I will talk briefly about Prospero, which is an international prospective register of systematic review. It's like a worldwide platform that we will include or register our protocol on it to avoid duplication of studies and to avoid bias. So it have four main purposes, which will ensure transparency and accountability of our research and prevent duplication, and also act as a timestamp or show our planning time of research. Also, it will increase the credibility of our research. So this is the main purpose of registration of our research in Prospero. So the third main step in our systematic review is literature search by using databases like PubMed or Embase or Coherence Library. And we start screening previous researches or papers from it. After that, we will go to the next step, which is study selection. Start by primary survey or primary search. We will search for just title and abstract by applying inclusion and exclusion criteria in the search options. And also we will use the PRISMA follow diagram, and Dr. Gaffar he will talk about it in the other part of this session. So after we choose our study and we filter the irrelevant or excluded studies, we start to data extraction by using the standardized data extraction form. For example, we can do it manually in Excel sheet, or we can do it in Confidence, which is also provide us with the method to do screening on it. And after we extract our data, we will assess our risk bias by using tools like the coherence risk bias tools. And after that, we will do data synthesis, qualitative synthesis, if it was a systematic review, or quantitative, if it was a meta-analysis. And the difference between systematic review and meta-analysis is that systematic review deal with both quantitative or qualitative data, and meta-analysis deal just with the quantitative data. So it's like a part of systematic review that is specifically in quantitative data. After that, we will come to the next step, which we will report the findings or the result of our study by using the PRISMA guidelines and checklist, and also discuss the limitation, strengths of the study, and implication, and also the conclusion that we get from this study. And this is the summary of our steps. Any questions? Now we'll go to part B. Dr. Gaffar will present it.
Thank you, Dr. Musab, for covering the first part of the session, and also thank you for the technical support in sharing the screen for us. Assalamu alaikum wa rahmatullah.
Welcome.
Good morning, good afternoon, and good evening, depending on your time zone. First of all, can you hear my voice? Is it clear?
Yes, it's clear. It's clear.
Thank you. My name is Gaffar Manhal, and I'm very glad to be here presenting this part of the session, which will be talking about the PRISMA guidelines. And it's a guidelines structured to ensure the transparent and complete reporting of the systemic reviews and meta-analysis. But before I begin my part, I would like to send my heartfelt sympathy to Dr. Nadir, whose father passed away recently. I hope may Allah have mercy on his soul and grant him Jannah, inshallah. And may Dr. Nadir and his family find comfort and patience during this difficult time. And I want to say also Eid Mubarak to everyone. And I hope this Eid bring peace and blessing to everyone. So the title of my presentation is PRISMA Guidelines, Transparent Reporting of Systemic Reviews, which will be a quick but comprehensive overview of the PRISMA guideline, why it's important and how it works, especially after the 2020 update. So next slide, Dr. Musab. Yeah, thank you. We will start by the definition of PRISMA. Actually, PRISMA stands for Preferred Reporting Item for Systemic Reviews and Meta-Analysis. And it's a standardized reporting guidelines to improve the clarity and transparency of the systemic reviews, because as we know, it's called systemic review as we want to avoid any sort of deviation. So it's very important to make everything standardized, and that's why it comes to the importance of the PRISMA to ensure that every systemic review will be done using the same guidelines. And it was first published in 2009, and after that it was updated in 2020, and it's widely used in medical and health research, as I say, to ensure the transparency of the systemic reviews. And actually it helps the reviewers, editors, and readers to understand, replicate, and to assess the validity of the systemic review or the meta-analysis. So the key reasons of the PRISMA guidelines and the importance of it. First of all, the transparency, as all the steps of the review should be clearly documented. And if you submit any systemic review to any journal, you should be you will be required to upload the PRISMA guidelines and to do the checklist of the PRISMA guidelines before you submit your systemic review. And after that, the reproducibility of the systemic review, as others can replicate the review using the same method. If I find the PRISMA guidelines of your systemic review, I can do your systemic review without any need to return to you for any reason. And also to ensure the completeness of the systemic review, to avoid any missing essential components. As we are human beings, so we can miss some parts from our systemic review. So it's better to follow the guidelines to ensure that there is no missed informations or missed parts from the systemic review. And last key reason is a standardization, as I said, to promote the consistency across the published reviews, to make sure that all the systemic reviews should be published using these guidelines. And to be talking in a practical way, the real world impact of this guidelines is to ensure that your work or your systemic review will have a high chances to be published, as many peer-reviewed journals will require these PRISMA guidelines to be followed before you submit your work. Next slide. The PRISMA guideline, according to the last update in 2020, includes 27 essential reporting items, and there are 7 sections. And actually, each section contains some part of these essential items, and each item contain sub-items. And in the end of our presentation, I will show you the PRISMA guidelines from their websites. But the 7 sections are the title, abstract, introduction, methods, results, discussion, and other informations in the end of the guidelines. And as you see, it's like the same sections of the systemic review, but with items in each section to ensure that you are doing that section appropriately. So we will begin with the step 1, which is the title and the abstract. And the title contains 1 item, which is the title itself. And the title should be clearly stated and report that is it a systemic review or it's a meta-analysis. As you know that the meta-analysis is an extra step in doing the systemic review. You will be analyzing the kind of secondary data that you are going to be collecting, as Dr. Musab said in the beginning of this presentation. So you will make sure that your title is accurate and representative to your systemic review. And you should add your title in the beginning of the guidelines. And the second part is the abstract, which is the second item as well. And you should use a structured abstract format, which is consists of the background, method, results, and conclusion. And actually, the PRISMA had guidelines also for or a checklist for the abstract itself, containing 12 items. And you should check the PRISMA for abstract checklist to ensure that you are writing the abstract in the way of the PRISMA guideline. And the importance of that, those 2 items, or the title and the abstract, where most likely most of the readers will see in the beginning of reviewing your your systemic review. So that's why it should be concise and informative and written very well, because if the title and abstract are deviated from the guidelines, most likely the reviewer will not be going to review the rest of your systemic review. Moving to the next step, which is the introduction and the objectives. We had two items in the introduction section, which is the rationale and the objectives. And in the rationale, you should describe the background and why your review is needed. And in the objective section, you should clearly state the research question using the PICO format, which mentioned in the beginning of the session by Dr. Musab. And a rapid briefing about the PICO. It's a stand for a population intervention and comparator or the outcome, the O section, and the population, for example, the adults with hypertension, and the intervention, for example, using a beta blockers, and you will compare with a placebo or any other drugs, and in the outcome, you should assess any kind of outcomes from this kind of medication, for example, cardiovascular mortality. Moving to the next step, which is the methods, and actually it's the most detailed section, and actually it's the most important section as well, because most of the peer reviewers in the journals will stress on this section, and if they want to accept or reject your systemic review, they will be reviewing this section. So you will make sure that this section is well written, following the PRISMA guidelines. And the key items of this section include the eligibility criteria, inclusion and exclusion criteria, and the information sources, which is the databases that you use to search for the data, and also the search strategy with a full explanation, including the keywords that you use to do the literature review, and the selection process, how many reviewers screen the studies. Usually a minimum of 2 reviewers should review the studies, and you should compare between reviewer 1 and reviewer 2 to make sure that you include or exclude the studies accurately. And then you should also report the data collection process and the data extraction process and the tools used in the data extraction. For example, many people used Rayan, which is a software and an app for doing the data extraction and the screening, and many others also use just Excel sheets. But you should also report this in the method section. Then in the method, you should also mention the risk of bias assessment and the quality assessment, and the tool that you used, as Dr. Musab saying that many people use Cochrane risk of bias tool. And also you should mention that if there is any synthesis of data, you should mention that how you synthesize this data, especially in meta-analysis, and which software it was used to synthesize the data from the secondary data that you are collecting. And actually, this is an example of the quality assessment criteria. And you should grade each of the items using a grades like this, 0 and 1. If you are doing the title appropriately, you will give it a high grade, and if not, you should give it 0 grade. And after that, you will collect all the grades, and accordingly you will assess the quality of the paper accordingly. Next slide. The next step is the result section, which is contain the items from 16 to 22. And the main points to be reported in the result section, and the most important actually, it's the study selection, which should be reported using a PRISMA flow diagram. And I will show you an example of this flow diagram, and we will discuss it in a while. And then we have the study characteristics, which include the sample size, the population, and the interventions. And after that, we have the risk of bias for each study, and it should be documented in a summary table after doing the risk of bias for each included study in your systemic review. And after that, you should also present the data or the quantitative data from each study with the confidence interval of each item in your result section as you're comparing. For example, if you are doing your systemic review talking about the Bain score, for example, you should document the Bain score in the using the mean and the standard deviation with the confidence intervals to make sure that everyone who is reviewing your systemic review and seeing the data can make sense of this type of data. And it should be standardized using the same measure to make sure that also any one of the readers can compare between the results easily. And also in this section, you will put the meta-analysis if it's done, and the synthesized data should be also discussed in this section. And the flow diagram, which is used to show the 4 phases of the study selection, which is identification, screening, eligibility, and the final included studies, is widely used, and it should be done in each systemic review. Well, this is an example of the diagram, the flow diagram, using or following the PRISMA guidelines. And if you reviewed or open any published systemic review, you will find a kind of this diagram in the beginning of the result section. And it's actually contain the 4 sections, which is the identification, which is mean that in the beginning of your systemic review, you should search the literature and to identify using your PICO and the keywords, following your search strategy and following the protocol. You will be searching for every study that contains the keywords, or every study that mention part of your PICO. And as you see in this diagram, they ended of about like 3,290 number of papers. And after that, you will remove the duplicates. As we know that we will be searching in different databases like PubMed and Google Scholar and other type of databases. So there is many duplicates. You should remove these duplicates also in the identification step. And after that, you should do the screening in 2 steps, which is the first step is the screening of the title and the abstract. And you should make sure that the screening done by at least 2 reviewers, and you should compare between the 2 reviewers to make sure that you are including or excluding appropriately. And after you screen the title and abstract, you should go for the next step, which is the eligibility, or the next level of screening. In this level, you should screen the full text. Also, you should do this step using at least 2 reviewers. And after that, you should compare between them. And as you see that when we are moving down in this diagram, the number of papers included will be less and less. And after that, you will end up with a few number of studies that should be included in your studies that were included in the screening of the full text, and you are making sure that this article or this paper should be included in your systemic review. Next slide, Dr. Musab. Thank you. The next step, which is the discussion and the other item. The discussion section include the items from 23 to 24, and the discussion section should summarize the main findings of the systemic review after comparing the results of all the included papers, and you should discuss the strength and limitations of each paper. And after that, you should interpret the results in the context of the existing evidence and the implications for practice and research. And the other item section, which is the last section, contain the items from 25 to 27, and it's include the registration part, which you should report in this section if the protocol of your systemic review is registered. For example, in Prospero, you should mention the registration number in this section. After that, if your systemic review is funded by any agency, you should mention the funding agency in this section also. And also, if there is any conflict of interest, should be disclosed clearly in the end of the PRISMA guidelines. Actually, this is a screenshot from the website for the PRISMA 2022 checklist, including the 7 sections and the 27 items. And each item, or most of the items, contain sub-items. For example, the data items in the method section contain, which is the item number 10, contain 10A and 10B. And you should review the PRISMA guidelines and this checklist. You should fill the checklist when you are submitting your systemic review. And the rest of the guideline or the rest of the checklist in the next slide. Yes, this is the rest of the PRISMA checklist, which is the updated version of 2022. And you will find in the website a Word document or a Word version from this checklist, and you should just download the document, and after that fill the checklist when you are going to submit your systemic review. So in summary and take-home points, the PRISMA is very important guidelines to ensure high quality, transparent, and reproducible systemic reviews. And it follows the 27 item checklist and the flow diagram when you are representing the selection of studies in your results section. And many journals require the PRISMA compliance. That's why mastering it gives you an edge to and to make sure that your systemic review had a high chance to be published. And also using the PRISMA is both a reporting tool and a planning guide actually for your systemic review to make the things much easier for everyone. In the end of the presentation, these references, you can just go to the PRISMA website and download the updated guidelines and the checklist, and also you will find the flow diagram guidelines and also the abstract checklist in their websites. And thank you very much. There is, if there is any questions.
Thank you, Dr. Jaffer. I have one question regarding selection the topic for systematic review. Is it advisable to select a topic in a specific area that is, I mean, like no available trials or no available randomized control trials?
Actually, thank you for this question. Not sure I will give you the most accurate answer, and we can also open the place for the people to answer the question. But my own experience in this area, I used to check the PROSPERO website to, if I had any idea to do like any systemic review, I would just check PROSPERO to make sure that there is no published or registered protocol in the same BICO. But the tricky issue after you choose the topic is if you choose, for example, a wide topic, you will find that there is too much papers you should screen and too much papers you should include in your study. And if you choose like a very specific topic, you will find there is a small number of papers that you can include in your study. So I think you should be in between of that. According to my own experience, you should not be that too much specific or that too much generalized.
Okay, thank you.
I can add at some point. A systematic review mainly depend on primary data. So you should have primary data, for example, randomized control trials or case control studies, and then you will have to extract data from it and put it in the systemic review. So it is required.
I see. Thank you. Thank you, Dr. Omar.
Welcome. Welcome.
Or Musab. Thank you.
Thank you very much. Any questions? Any other questions?
Hi, Doctor. Thank you so much for today's presentation. I just wanted to ask about
Do you want me to open the PowerPoint again?
what I wanted to ask about is specifically the risk bias assessment tools, because you mentioned I think one, which is the cohort one, but from what I know that there is multiple ones. Does it make a difference which one we choose for the specific studies or not? Thank you so much.
Actually, it's required to use one of these assessment tools, but actually I don't know if it is there is a change to use one over others, or if it will not make a difference. I don't know personally.
Thank you so much.
Dr. Nader give us an answer about this question?
Anyway, I think regarding your question, I can just add, according to my experience, most of the Sudanese researchers that I worked with, they use the Cochrane tool. And actually, I'm not very familiar with this tool, but and actually, I don't know the other tools, but I know that there is other tools used. So it depends on mainly on the expertise of the researchers or the expertise of the team of the research that are doing the systemic review. But if Dr. Nadir can add on this question.
Sorry, I stepped away for a minute. What was the question?
She asked actually about the risk of bias assessment. And we mentioned one tool that used in the risk of bias assessment, which is the Cochrane tool. And she asked that if there is any preferences and if it's, for example, it's better to use Cochrane or it's better to use another tool. And me and Dr. Mustafa were not very familiar with other type of tools in this risk of bias assessment.
Yeah, there are different ones, but yeah, as you said, you can use either. There is no, I think, preference. They want you to show that you identify if there is a bias or not, and what did you do about it if you find one. So Cochrane tool is okay. If you find any other tool that can be used, it's one of the things that you need to identify and show that you search for it. If there is no bias, then you will say, we use this tool to identify and we found none. Thank you.
Thank you. Thank you for your answer.
Thank you, Dr.
Thank you, Dr. Nadir. I think we're done from our side. So thank you, everyone, for your attention and your time. And thank you, Dr. Musab, for your support. I hope our presentation was helpful to clarify the steps in doing the systemic review and the PRISMA guidelines. And once again, Eid Mubarak to everyone. And good night, and have a good night.
Thank you both, Dr. Musab and Dr. Jaffar, for great presentation. And I would like just to add one comment, which is it's easier to say that these are the steps, but it's gonna make sense when you do the actual project or the research project. Like you can participate in part. Usually what I advise fellows is to take some task. You don't have to start from A to Z, all these steps you need to do. But if you work in a team, you can do part or some task, and then next project, you will be able to complete different tasks maybe. And by the third project, maybe you will know for sure what the steps and how to do them, and you'll be the expert and you can teach others if it makes sense. Thank you so much for a great presentation again. If there are no more questions, we can move on to the next item. Thank you. Dr. Othman, when you are ready.
Okay, Assalamu alaikum wa rahmatullah. Hello everyone. My name is Dr. Othman, and I'm more than happy really to be with you in this meeting and to present the topic of type of graphs. Is the screen okay? Is it clear for everyone? Type of graphs and how to create them in Google Sheet.
Not yet. We don't see this.
Not yet. Okay. Second. Okay. Just a second.
Sure. You have the presentation in a PowerPoint file or Google Slide file?
Yeah, I'm going to share my screen. It's loading now. Yeah, I think a couple of seconds and it will appear forever. While we are waiting for the screen to load, yeah, okay, yeah. Is it clear for everyone now?
Not yet.
I think, yeah, I think. Can you see it?
No.
Not yet. Hmm. Okay, I'm not sure what the problem, but
What device are you using? Laptop or desktop?
sorry.
Which device are you using?
Yeah, it's a PC computer, a desktop. Yeah.
Okay.
Maybe I need to switch to another device. Yeah. Um,
Do you have it as like in your computer or online?
sorry.
Do you have the presentation as the PowerPoint file in your computer? You want to use?
Yes, it's in my computer. I will present it in a slide, and also I will to show you an Excel sheet. I'm planning to do an active session, so I prepared an Excel sheet, and we will go all over it. Let me try for the last time. If it didn't work, I can change my device. Let me give it a final try. Okay.
If it didn't work with you, you can send it to me and try with my laptop.
Okay. I will try doing that also.
Okay.
Hello, everyone. Dr. Osman.
Yes.
I share my screen. It's here. Please check it.
Okay, I will send you a link. I will send you a link for the Excel sheet, and so that you can open it from your device and we can start. Okay. I will send you the link.
WhatsApp. Yeah, I already sent it. Just to check in the Zoom meeting if it's clear to all of us.
Okay, I send you another link. Can you just check your WhatsApp? Yeah. The link contains the Excel sheet.
Yep.
So
If you can start with type of graphs, if it's clear and Dr. Osman. Are you ready?
Yes, I can hear you, but yeah, it didn't appear for me yet, the screen. Yeah. Okay. Yeah, I think I can see it now. If it's clear for everyone, we can start. Is it clear?
Yes.
Sorry. Okay. First of all, I'm sorry for that technical issue, but we can just start. Just to remind you, my name is Dr. Othman Ahmed, and I will be presenting to you all the topic of um, type of charts and how to create them in Google Sheet. I think we all know that graphs and charts are a crucial part for of any research. So I hope by the end of this presentation, I will add some value about that point for all of you. So let us start. First of all, or the first point in my presentation is how to create a graph in Google Sheet. So yeah. Okay, let's just go over the content. We will learn firstly how to create a graph in Google Sheet. It's a simple step, really. After that, we will learn the basic point about each type of charts. We have the line charts, number one. Number two, we have area charts, three column charts, bar charts, pie charts. And if there's additional time, we can talk about other special type of charts. So, Umar, can you now open the Excel sheet?
Okay.
If you could open it from if you could open it from the link, it will be better, so that we can.
Don't have X.
Ah,
I don't have XML
there is no
file.
access?
Yeah.
Okay. Okay, no problem. We can just.
I will try to open it with my laptop, Dr. Osman.
I will be very thankful if you could do it.
Just give me 1 minute.
Yeah. Okay. By the way, while Musab opened the Excel sheet, does anyone have any question or any point of view about charts? He want to share it with us. If anyone have any point or any question, please feel free to address it. Yes. Oh, that's great. That's wonderful. Thank you, Musa. Okay, but it is horizontal. If you can rotate the phone a little bit. So
I think Dr. Omar opened it.
Okay, Dr. Umar, can you rotate the screen, please? Okay. Yeah, I think this is this is your screen, Dr. Musab. Is that right?
Yes. This is my
Okay.
screen.
That's great. That's great. Okay. We say that the first step that we are going to learn today is how to create a graph in a Google Sheet. Okay. Can you go down or zoom in the lower part? Yeah, zoom inside it. Yes. Okay, make it maybe one. Okay. Can you zoom in more? Make it maybe
100.
Maybe two. Yeah. Okay. I think it's clear now. Okay. First of all, we should have a table. We should have a data. And this table is an example. It's just an example. You can imagine that you have any type of table. All what we should do is highlight the table. Can you highlight the table, Dr. Nota? Highlight it from the cell of student to the cell of 35. Yeah, move to the right. Go down. No. Yeah. Yes. Highlight. Yes. Excellent. Very good. After that, you can go to insert, or by Arabic you can say idraj. Idraj.
I don't have access to it.
Okay, no problem. And assume we are in a normal situation, you can press that button, or you can press insert. It will appear that a small icon and labeled by chart. Just you click that button, and the chart will appear in front of you. That's all. That's really all about how to create a chart. And that was the easy part. The difficult part, maybe, will be knowing to choose which chart is the more or the most suitable for your data. And at that point, or we will spend the rest of the presentation talking about that point, how to choose the suitable, the most appropriate chart for your data. So can you go down and press the link sheet, the line sheet, if you can, down. No. By your mouth, go down. You see, how can I describe it?
In which area?
On the process there.
Line, yeah. And
In the bar?
Yes, in the bar. Yeah. Yes, exactly. Thank you very much. Okay, the first type of charts we have today is the line charts. And what's unique about line charts is, I can say, if you can describe the line chart by one word, we can say time. It will help you represent your data and follow it among a period of time. So can you go a little bit down? Yeah, down. Yes, okay, just stop here. Okay, very nice. We have the first example here. As you see, if we concentrate on the chart, we have a timeline 2014, 15, 16, 17 on the x axis, and on the y axis we have any values. So the crucial part here, or the most important part in the line chart, that we should have a timeline, and that will always be represented by the x axis. Okay, let us go to the table, or let us focus on the table at the left. You can see the years, 2014, 2015, 16, 17. By putting these data by this order, it will be represented in the chart by the x-axis. I hope it's clear for everyone. Okay, that's all. That's all the important points about the line chart. So you can track any variable, any values on a specific time. Now let's go to the second example. Downward, please. Okay, this is the same as the first one, except that there's a three different categories. On the first example, we have just two, so you can add 3, 4, 5, 6, and so on. Just to repeat, the main point of the line chart is that we represent our data based on the time. If everything is clear about the line, we can move on to the second type of graphs, and what we call it area. So can we go? Yeah, the area. The area is the area chart. It's just typically the same the same chart of the line, except that it maybe shed the area below the line. So it represents that we have. Can you go downward, please? Yes. Okay. That's a beautiful example for area graph. So it gives another meaning. Maybe for anyone can see this chart, he will maybe feel that. For an example, here we have the months, the time, by two brackets, and the values. the values, we can see the expenses or the revenues. As I said, it's the same as the line, except the appearance. Just the appearance will difference from the line and the area. The area will the area below the line will be shaded by any color you choose. So I think these two type of charts are pretty similar to each other. So we can move to the third type of charts. Or yeah, let us talk about an extra information here about the area chart. An extra way or an addition way to represent the area chart is to use what we call an 100 area chart, as you can see in the screen. The unique thing about this chart is you can use it as a pie chart, but on a different point of time. So if you can, as you can see here, we have a we have a four variables, or we have a four categories, or a four variables, and we can see how it will be represented on January, and after that we can see how it will be represented on February, March, and so on. So I think it's really helpful for everyone want to represent his data by a chart, by using a pie chart on a different point of times. I think okay, can you go down a little bit? Yes, okay. We call that type or that subtype, we called it step chart. I think the main point is just the appearance of the chart. It's still an area chart. All the area charts are shaded, the line, the area below the line will be shaded, just like that. Okay, can you move downward? In this example, we represent two variables. Can you go down? And the final example, we use it as a 100% and stepwise. Okay, I think that's all about the area. We can move to the columns. Okay, the column is actually, there's a lot of differences between the column and the previous charts we talk about the area and the line, because here on this chart, on this type of chart, we mainly don't rely on the time. The main focus of this chart is to compare between different categories. So the main is not, the time is not an issue here, or the time is not the main point that we want to represent. Can you go down a little bit? Skip the first example. Let's go to the second one. Yeah, I think it's more clearer. So as you can see here, we want to represent our data, which was a survey result. So we can see by just looking at the chart, we can see that we have maybe a satisfied, which is we can compare the satisfied with the very satisfied, with the natural, with the unsatisfied, by just looking at the chart. So the main issue or the main point is comparison between different categories, ignoring the time, or the time have no role in this chart. So just you can go up for the first. No, go up. Yeah. Okay. In this example, yeah, I know you can all see that there's January, February, March. Some of you can assume that we should use the time here, but that is not the case. The time here is, I will explain it. The main point here is to compare two variables. So we are really, the main point, we are comparing the expenses with the revenue. And we add the third variable, which is, in this case, the months. It could be anything. It could be a geographic area. It could be a country. It could be anything. It shouldn't be the time. I hope you got the point. So we can go to the final. Yeah, go down. Okay, this type of chart, it's also a column, but it's represented by a 100%. In another way, we can say it's a pie chart also. It's a pie chart, but will be represented in different categories. So that is all about columns. That's all about columns. We can go to the bar chart. Yeah, I believe that the bar chart and the column chart, maybe, yeah, there's a lot of relations between them. I think they are pretty similar to each other. So the main idea here is also that we are focusing on the uh, categories. We are focusing to compare between different categories. As you can see in this example, I think the main difference is the view, the axis, the axis. As you can see, this data is represented horizontally, and not like the column. So if we take that example, we can see that this chart is comparing between the juniors and the seniors based on their grades. Simply, can you go down? Okay, in this type, we comparing different categories. No, yani we don't have subcategories here. We're just comparing one variable between another one. Yani we have different variables and we comparing them by the percentages. Okay, can you go down? Finally, as we always do, we have a 100% stack bar chart also. So we can compare between the north region, the south region. We compare between them based on, here they use the months, but we can use anything like the grades, maybe diseases, anything. I hope it's also clear for everyone. We can move to the final main type, which is, yeah, the pie. The pie chart. Yes, the pie chart. I think it's the most familiar type of chart for everyone. I think it's really eye-catching. It's very easy. Can you go down? Yes. Yeah, I think by just taking a look, you can understand everything. So it represents the main point of the pie chart, or the main use of the pie chart. It is to represent the part of the all. So yeah, the part of the all. If you have any data and you want to represent the part of the all, the best way to use is the pie chart. And as you can see, we have a different style, we can say, of the pie chart. We have the pie chart, and down we have something we call the donut chart. You can also make a 3D pie chart, and there is a lot of options here. But the main idea that we use it to represent a part of whole. I hope everything is clear till now. Does anyone have any question before we go to the special type of chart? And I think it's the most interesting part, the special type. So, does anyone have any question till now? Okay, maybe I should ask some question, but I think let us complete the rest of types, and then I maybe will ask you one or two questions. Okay, other charts, yeah, we have three other charts, or three special charts. The first one, what we called it, histogram. Can you go down a little bit? Yeah, histogram, it's very simple. As you can see on the left, we have a test scores, and 62, 55, 70, and going, and so on. So by using this chart will help you categorize them um, uh, by making them in a normal distribution. So you can see from 50 to 60, from 50 to 70, from 50 to 80, and so on. It will re-represent your data in a distributive manner. So yeah, I think it's very helpful when you are representing some data, maybe grades or maybe incidents or anything. So we can move to the second type. Yeah. We call this type the gauge, the gauge chart. Mainly, we use it to represent how far we are from our goal, simply. So, as you can see on all these four gauges, the maximum point is 75K. Yeah, I think so. 75. So we can see that the sales or the sales in 2015 was far away from the maximum, or I think we can say it's in the middle. We can see that on 2016 we almost reaches the maximum. I think the idea was clear from or how to use this type of chart. Finally, yeah, the final type of chart for this presentation is what we call the geo chart. I think it's a really helpful. Yeah, it's really helpful way to represent anything about a geographic areas. If you have any study or any research and you want to discuss or want to talk about different type of or different area, different geographic area, you can simply use this chart, and I think it's a very good way or a very nice advantage in Google Sheets. I want you to do something, Musab, if you don't mind. Can you just add below Germany? Can you just add Sudan? Can you write? Can you type Sudan?
Unfortunately, I can't
Oh,
because I don't have a subscription on it.
no problem. No problem at all. But okay, if we wrote Sudan and we just give it any value, it will appear as green or blue or red or any color we choose on this map. So it's interactive and it's really helpful in representing your data. I think that's all. That's all about Google Charts. So let us go back to the first. No, no, yeah, the content. Yeah, no, the content.
Content.
Yeah. And let us summarize what we have discussed before I ask you one question, maybe. Yeah. Can you go up a little bit? No, no, up. Yeah. Okay, today, just to summarize what we have said, we learned how to create a graph. Unfortunately, um, there was a technical issue, but I think the idea was clear. In addition to that, it's a simple step. It's not hard to create a Google Sheet. What we say that the most important part is how to choose the suitable chart. We talk about the line and the area, and we say that the main point of these two types is the time. Yeah, the time. After that, we talk about the column and the bar, and we say that we don't need to use the time in this type of chart. We just want to compare between two different categories, or three, or four, or so on. Finally, we have the pie chart, and I think you all know the pie chart. At the end, we discuss some special type of charts. So I think I finish. So if anyone has any question, we'll be happy to hear it, or any extra additional point anyone can add. It will be very valuable.
Thank you again, Dr. Othman. This also great presentation and very helpful.
Okay, thank you.
For Dr. Othman or any of the other presenters?
Hello, everyone.
Hello.
Omar Mohammed, the Blue Team 2 leader. I just want to extend my heartfelt thanks to all the presenters for the outstanding performance and for ensuring that presentation runs smoothly. Special thanks also to Dr. Nader for this opportunity. Thank you all.
Thank you, Dr. Omar, for organizing, and all the team, all the presenters for great presentations and your time, your effort, and all those who joined today. thank you. It's a time, but you took some time off and attended the meeting, so we really appreciate that. And for those who will look at the recording in the future, thank you for watching, and I wish you all the best. Any questions, any comments, suggestions, any other thing that you want to share before we adjourn? If not, then I'll see you next week, hopefully. And in the meantime, if you have questions or any thing that we can help you with, reach out. You can reach me via email or text or WhatsApp or call me. I'll be happy to help as much as we can. Thank you, and I wish you all the best and have a wonderful day or night. Happy Eid, and we'll see you next week. Assalamu alaikum. Thank you.
Thank you, Dr. Nader.
Thank you so much.
Dr. Nader.
Thank you, Dr. Azza.
Thank you, Dr. Nader, for this great opportunity.
Thank you for your help, Dr. Musab.
Thank you.
Dr. Seema, thank you. Have a wonderful day.